All right, good morning, everyone. My name is Molly. I'm one of the R3s in the program. For those of you who I haven't met, I'm happy to be here this morning to talk a little bit more about PE, really in the inpatient setting. I think often as residents, we get patients from the ED just started on a heparin drip, and then from there, we're just sort of in auto mode. And so I wanted to slow down and review a little bit why we do what we do for PE and where there is strong data to guide us and where there is not yet. I have no disclosures. And so to give a little bit of an outline for how I want to approach the next 40 minutes or so, I want to kind of briefly go through these upper bullet points and spend more time as we move down. But just to set the stage a little bit, we will quickly review what a PE is, what are some signs. I want to review EKG and echo, essentially two things that you can do at bedside while you're trying to figure out your level of concern for whether someone has a PE or not. I'll talk for a few minutes about systems that we use to classify PE severity and if those systems are related to management and outcomes or not. And then I'll spend some time talking through a few cases just to think about how we decide which management strategy is right for our patient. At the end, there will be a slide of take-home points. And please, if you have questions along the way, feel free to drop them in the chat, or you can also unmute. So briefly, I think we're all familiar with what a PE is, but to be specific or explicit about it, a PE occurs when there is obstruction of the pulmonary artery or one of its branches. What we sometimes forget, I think, is that the obstructing material doesn't have to be a blood clot. It could actually be air, fat, or tumor as well. For the purposes of today's talk, we're going to focus on PE related to blood clots. We will also today focus on acute PE management, but we'll acknowledge that PEs may be acute, subacute, or chronic. It's actually the third most common cause of cardiovascular death for patients who are hospitalized in the Western world after MI and stroke. And what I was interested to learn is that often these deaths that occur from PE happen in the first several hours to days. And so having a high level of suspicion and diagnosing early is really important. I was interested to review some of the presenting symptoms that we see for these folks. I think we all have a general illness script for PE and what the presenting symptoms are. But in actually looking through some more recent cohort studies, I was a little surprised. I pulled one here where they looked at a little over 300 folks in Boston who were hospitalized for submassive or massive PE. And I think we're probably not surprised that the most common presenting complaint was dyspnea, followed by tachycardia. I think we're pretty aware of those presenting features. But what I was a little bit surprised to see was that only half of their cohort was actually hypoxemic at time of presentation. I think we often in the hospital, when we, see someone who's newly dyspneic or more tachy, we often invoke, well, they're not hypoxemic, so probably not PE. But I think reflecting on this data here and some of the other cohort studies I looked at, I think that gives me a little more pause now when I'm invoking lack of hypoxemia as reassuring against PE, especially because these were folks who had either submassive or massive. Some of the other symptoms that we also think about, chest pain, syncope, hemoptysis, things like that. Chest pain is fairly common, but syncope and hemoptysis are actually rather uncommon. Again, my little animation to highlight, I thought the hypoxia at 50% was interesting. I wanted to spend a couple of minutes talking about things that we can do at the patient's bedside when we're trying to figure out, do I think that they have a PE or do I think something else is going on? This patient has a little bit of an AKI. Do I want to send them to the scanner? Separate question of whether or not contrast nephropathy is a real thing or not that I will not talk about today. But while we're at bedside trying to figure this out, we can get an EKG. It's quick and easy. The most common thing that you will see on EKG is sinus tach, which is very not specific. But there are some other things that I think we've learned about either in med school or sort of in passing. I was surprised to learn, I was aware sort of peripherally that the S1QT33 thing that we learn about in med school is not super common, but in looking through some studies, it's actually really not that common. It's only about 1/5 of patients who present with those EKG changes. So lack of that is certainly not reassuring that this patient doesn't have a PE. The most specific finding in a couple of studies that I was able to review was actually evidence of RV strain, both in the precordial leads and in the inferior leads, which I think makes sense when we think about what's happening with a PE, right? You have this blood clot, you have hypoxemic vasoconstriction, the pressure in your pulmonary vascular system is increasing. And in response to that, the RV is trying to push against this higher pressure. It's starting to dilate, the RA is starting to dilate. And so there's some structural changes happening. Sort of also related to that process, you'll sometimes see a new complete or partial bundle, as well as right axis deviation, because as the heart is enlarging, the axis is actually shifting. But unfortunately, you can also have a stone cold normal EKG. So some of these things I think can be clues. Really, to me, I read them more as signs of possible right heart dysfunction than acute PE. But again, while you're trying to figure out your game plan or your next step for workup, these can be helpful clues to think about. The other things that we can do at bedside, and I think it's been cool over the course of residency to see that seems like we're really doing a lot more bedside ultrasound assessment. We can do that when we're assessing our patient and we're trying to figure out what's going on. So this screen grab here is an example of one of the common signs that we can see in PE. Does anyone want to shout out what it is?
The right ventricle is quite large. It looks almost larger than the left ventricle.
Agree. And is that normal? That is not.
No, that's not normal.
Yeah.
And there's also I don't know what the name is, but the apex of the heart is hyperkinetic.
Yes, love it. That is exactly what we're trying to demonstrate here with this screen capture. So this sign here that we're seeing is called MCCONNELL'S sign. And what we're seeing here is, as you mentioned, we have a couple of things. One, if you look at your right ventricular free wall, so that's going to be the leftmost part of your screen, it is relatively akinetic. In contrast to that, the RV apex, as you mentioned, I'm sorry, I don't know who that was, but as you mentioned, it's hyperkinetic. It's moving really quickly and it almost looks like a trampoline. So the other thing that people will sometimes call this sign is the trampoline sign. And so thinking a little bit about why this happens, I was trying to read to understand the pathophys a little more. Again, as I was saying, with your PE, you have increased pulmonary vascular resistance. And so the RV, as it's trying to push against that higher pressure, will start to dilate. And as it starts to dilate, it will become more spherical. It's not going to become a sphere, but it will become more spherical. And as this happens, the wall stress is going to increase. But essentially what happens is the wall stress is not evenly distributed across the RV. And so basically the free wall gets mechanically stunned because of the distribution of this wall stress, but the apex is spared. And so that's part of why you see this very hyperkinetic apex. Something else that I learned in preparing this talk is that the RV apex is tethered to the LV apex in a sense. They share a lot of the same muscular fibers. And so as the LV apex is squeezing away, it kind of pulls the RV along with it. This sign is really not very sensitive. So absence is not going to reassure you that you do not have a PE. It was interesting as I was reading, it seems like the specificity was pretty variable across studies. Some cited very, very high specificity in the high 90s. Others were less excited. But what I seem to see that was more consistent across studies is that the positive predictive value for this sign is not that high, kind of on the higher end, it was in the 60s. So I think the way we can think about interpreting this at the bedside is that if you have a patient with pretty high pretest probability of having a PE, this is probably going to be a helpful rule-in parameter. But if you are not as sure, maybe this patient also has pulmonary hypertension or other reasons to have RV pressure overload, this may not be the thing that's going to rule in and make you think that there's a PE. Here is the other sign that we sometimes see when we are doing our bedside assessment. Whereas before we had our apical 4-chamber view, this is a parasternal short axis view. And so the chamber that we see closest to the probe at the top of the screen is the RV, and the chamber underneath it is the LV. Can anyone shout out what they think is going on in this screen grab?
Is it flattening of the septum, the IV septum?
It is, good job. Anyone know what that is called? The name of the sign?
The DSIGN in the chat from Kelvin.
Love it, yes. So this is the DSIGN. And as we're having that RV dilatation against the increased pressure in the pulmonary vascular system, you have shifting of that interventricular septum. And so instead of that LV being nice and donut shaped, it adopts that D shape that we see here. And what I wanted to note here was that when you're looking at this at bedside, pay attention to when you see this D. If you see this D that exists in diastole, right? So as that black area in the LV is getting bigger as the ventricle is filling. If you see it in diastole, but then in systole it disappears, that's a sign of volume overload. If you, however, see that D shape, both when the ventricle is filling and when it is contracting in systole, if you see it throughout the entire cardiac cycle, that is a sign of pressure overload. And that is what happens when you have a pulmonary embolism. Pressure overload can also happen in other pathologies, if you think of anything that increases pressure in your pulmonary vascular circuit. But it's important to make that distinction, because if you're only seeing it in diastole, maybe you've just got a volume overloaded patient for other reasons. This sign is also not very sensitive, not very specific. But again, I think the way I think about using this at the bedside is, particularly if I knew what their echo looked like a few days prior, if I see this new change in conjunction with new dyspnea, new tachycardia, I think it certainly raises my level of suspicion. So to transition a little bit, I wanted to talk about how we think about the severity of PE. I think we're all pretty familiar with thinking about them in the broad categories of a massive PE is a PE with shock, essentially. A submassive PE is a PE in which the patient is hemodynamically stable, but either has imaging evidence or biomarker evidence of right heart strain. And the low risk PEs are essentially PEs that fall into neither of the above categories. I was interested to review some of the other ways we define PE severity, because to me, you would like to think that the way we categorize it will help us determine management. And I think it does for the low risk folks. We know we can kind of safely treat them outpatient. The patients who are hemodynamically unstable, obviously we're not going to sit on that and see if they get better. But this submassive group is really kind of hard to tease apart who needs what and when to prevent risk of further hemodynamic compensation or further VQ mismatching. And so it's interesting to me, at least, that some of the other societies that have reviewed how to risk stratify PEs do it a little bit differently than the AHA and ACCP. The European Society of Cardiology has a similar definition for their massive or what they call high risk PEs, but for the intermediate risk PEs, they actually think about this a little bit differently. So first rule, this patient has to be hemodynamically stable. But then after that, the next thing that they use to figure out if this patient falls in this intermediate risk category is the PE severity index score. And that is a clinical risk calculator. It was developed almost 20 years ago now, in 2005 or so, I think, based on a review of a very large cohort of, I think, about 15,000 patients. And the idea was just to use routinely available clinical variables to figure out risk of 30-day mortality from any cause. So you go through this list of variables, a patient gets a score. If they have a score of at least 65 or higher, they're going to be categorized into one of these 5 classes, 1 being the lowest risk class, 5 being the highest risk class. And this is supposed to help us think about risk of mortality. And what I think is interesting here is that if you look at these variables, none of them really use imaging findings or lab findings. The clot burden is not included here, which I think is interesting when we, often will invoke, oh, this patient has so much clot, if they throw any more, they're going to code. And I'd like for us by the end of this talk to kind of challenge that assessment of this kind of one-to-one correlation between size of clot burden and risk of hemodynamic instability. So the ESC uses this index score, and for any patient who gets a score that bumps them into one of these classes that have some elevated risk of 30-day mortality from any cause, that patient will factor into this intermediate risk group. And so interestingly, not all of these patients actually have evidence of right heart strain, which again, I think makes us think about what are underlying risk factors that patients have that may make them unable to kind of increase their cardiac output to match and overcome that pressure that's put upon their heart by their PE. The last thing I wanted to comment on regarding this is that in 2015, CHEST did a meta-analysis of, I think, 40 different studies that looked at risk prediction tools. That the goal of those tools was to identify patients who are at high risk of early mortality from any cause. And there were 11 risk calculators assessed across these 40 studies. And what I wanted to draw your attention to was the bottom set of data, the pulmonary embolism severity index. The PESI is sort of a simplified version of that index, the European Society of Cardiology guidelines, and then OJESCI guidelines as well. But there are, of course, several other risk prediction calculators as well. And for this group of studies and risk prediction models, they were quite sensitive, but they really weren't very specific. So they were really good at not missing anyone with higher risk PEs, but then for all of those people that they said you have a high risk PE, only half of them actually developed any hemodynamic compromise. And so that's a pretty large chunk of people that you're sort of screening in to then not actually see that effect that you're worried about. So we really don't have a great tool yet to figure out who are the ones that are highest risk of decompensation within that submassive category. Seems like, based on what we know so far about these models, some of them seem to be helpful at identifying patients who are low risk of having enlarging clot, hemodynamic compromise, can be safely treated in the outpatient setting with anticoagulation. But we really don't have a lot of data, don't have a lot of accurate prediction modeling to figure out for the patients in the submassive category who is going to decompensate on us and develop shock, needs more urgent intervention, and who could just coast along on anticoagulation. Obviously, in the massive setting, we don't sit on that and wait and see. So really what I'm talking about here is that submassive group where their right heart is working a little harder, and that's concerning, but we really just don't have a great sense of how to figure out who needs intervention quickly and then what kind of intervention do we need. Briefly, to think about just kind of the general options for PE management. We'll talk about these in a little more detail as we go. I think it was kind of like an escalation of therapy. The standard, I think, as we all know, is anticoagulation. And the goal of anticoag is not to break up existing clot, which I think is sometimes what patients think. It's actually to prevent the current clot from getting any bigger and to also prevent new clot from forming. If we're sort of going up our ladder of therapies, the other kind of bucket that we can think about is reperfusion therapy, where you're actually trying to bust up that clot, improve hemodynamics, improve EQ mismatching. I think we're all somewhat familiar with thrombolytics. Generally, we use alteplase here in the US to actually break up the clot. There are also other catheter-directed therapies. Surgery is an option, although there's a lot of caveats in trying to figure out who is appropriate for that. And then for folks who are very unstable, bad obstructive shock, mechanical support devices can actually be used to help support these patients while more definitive therapy is pursued. And for folks who cannot tolerate any sort of anti-coag, that's when we think about an IVC filter. But I'm not going to spend too much time talking about IVC filters today. If there are no questions so far, I now want to transition to a couple of cases where we can talk a little bit about trying to select appropriate management. This first case is a case that I saw at Harborview a few months ago, and I'm curious to see what you guys think about it. This patient was a 32-year-old man. He had no known past medical history, and he presented to the emergency room with neck pain that had been going on for 2 months or so, had been getting progressively worse. And then over the past month or so, he'd also noticed left upper extremity numbness. He was well appearing in the ED, he was non-toxic, his vitals were stable. However, his neurologic exam was focal and he had some left upper extremity motor deficits. I believe he also had some sensory deficits. Imaging of his neck was pursued and he was found to have very severe cervical canal stenosis. And so the ED had consulted neurosurgery who wanted to take him to the OR as soon as possible with concern for unstable C-spine. He was admitted, was waiting for his bed on NCCS. And then interestingly in the ED, while he was waiting for his bed, desatted, though his other vital signs remained stable. And so the ED got a CTPE for this gentleman. And this was his CT. Does anyone want to comment on what they see here?
Have a lot of gasps from the audience in the chat.
That was how I felt too.
Bad news.
Saddle.
Yeah, that's a saddle PE. That is an acute clot burden that is in that pulmonary artery in the main part, and then also branching into the left and right main. I already told you guys his vital signs, which through his ED course, they were stable. The only thing that changed was new hypoxia, for which he needed a couple of liters of oxygen. So given that, how would we characterize the severity of this PE? Okay, well,
Question in the chat of any evidence of right heart strain, what are their vitals?
yeah. Well, let me show you this person's heart on CT. Does that suggest anything about the patient's cardiac function to you guys?
We have massive in the chat.
Yeah, so this patient's vital signs were stone cold stable. So this was a submassive PE because he was not hemodynamically unstable. But what I hope you can appreciate from looking at this slice of his CT that is showing his heart is that the RV is pretty big. So this RV to LV ratio is concerning. And further studies were obtained. His biomarkers were elevated. I think I just forgot to put the bullet point in here, but his echo also showed concerns for right heart strain. And so at this point in time, a motivated PERT was activated. And so if you guys were taking care of this patient, I'm curious to know what you would be thinking about in terms of his management. I'll tell you what happened, but I'm curious to know what folks think first.
In the chat, we have the risk benefit of thrombectomy.
Yeah, I think that's a great question.
Systemic TPA, like thrombolysis.
Okay, so thoughts about doing lytics for this patient?
Other thoughts? Monitoring the ICU, discussing with the IR for catheter directed versus systemic TPA. Others are saying giving clinical stability, probably just anticoagulation. And then other thoughts complicated by the acute surgical need as well.
Mm-hmm. Yeah, I think, thank you guys for sharing those thoughts. I think what everyone just shared pretty accurately reflects the discussion that happened when this patient was brought to the attention of the PERT team. There was a lot of back and forth discussion about what to do for this gentleman who was hemodynamically stable, but everyone was appropriately concerned about him with his evidence of right heart strain. But he also had an unstable C-spine, and he was a young, healthy guy, already had neurologic deficits. Anticoagulating him would delay his being able to get to the OR. And do we want to risk further neurologic injury by deferring OR? So what ultimately happened was he was not anticoagulated. Neurosurgery was trying to get him to the operating room as quickly as possible. Because of that urgency for getting him to the operating room, he also was not given any lytics, either systemic or catheter directed. The MICU attending who responded as part of the PERT team consulted IR for question about mechanical thrombectomy. She, I think, was concerned that this patient, we didn't really know how long he'd had this PE for. She didn't know if he could throw more clots or if his RV was just kind of a ticking time bomb and would progressively fail. But IR, for reasons that I can't comment on as I was not part of the discussion, deferred mechanical thrombectomy, I think invoking that he seemed clinically stable. Ultimately, this patient did not make it to the OR, and a couple of hours after he was admitted, he was noted to have been getting up from bed to go to the bathroom, and he lost pulses and suffered a PEA arrest about an hour or two before he was supposed to go to the OR. He got lytics twice during the code. ECMO team was consulted during the code. I think cardiothoracic surgery was also consulted during the code. But unfortunately, this patient really wasn't able to be reliably resuscitated. He just would get Ross and then Brady right back down and go back into PEA. And so after about 90 minutes of CPR, this patient passed away. And it was a really devastating case, I think, for everyone involved. And for me, I think it really highlighted how hard it is to know what to do for these patients who are submassive, they're hemodynamically stable, but who's to say that they're not going to become unstable? And how do we kind of know when to pull the trigger for more aggressive management? I think the other thing that's a little bit hard to know for us on the medicine side is what was his neurologic risk, and could he have safely had surgery deferred, or was that really something that he needed immediately? And so a lot of complicating factors for this case, but I think definitely very upsetting. And it was hard to not really have a 100% clear sense of what the right management was. Ultimately, everyone used their best judgment and was trying to do what was best for him. But I think it highlights that we still have work to do in trying to figure out how to manage these folks effectively, especially when they have other medical conditions that may complicate that care. I think to use that to talk a little bit about management of submassive PE, I apologize, this is a busy slide, but to be a little bit more high level about it, what I want to emphasize is that in general, for patients who have a submassive PE, that is patients who are hemodynamically stable but have either imaging or biomarker evidence of right heart dysfunction, they should be getting anticoagulated as soon as possible unless there's a strong contraindication. And again, the anticoagulation is not busting up that clot. It is just preventing new clot from forming. The question of systemic thrombolytics for these patients with hemodynamically stable submassive PEs is actually pretty controversial. There have been, in short, a variety of studies on this topic, and there's not really a clear consensus. There are some studies that do suggest that for patients with a submassive who get systemic thrombolytics, there is an improved mortality benefit in the short term, but there is elevated risk of catastrophic bleeding, including intracranial hemorrhage. There are other studies that suggest there is not a mortality benefit and there's still an elevated bleeding risk. I think a study that gets talked about often is a study whose name I don't know how to pronounce, but you see it typed there in the chat, PATO, however you'd like to call it. And for these patients, they had submassives and they were treated with either tenecteplase plus heparin or placebo and heparin. And so the group who got TPA did a little better. Fewer of them developed instability. Fewer of them developed shock, and they had an improvement in their risk of all-cause mortality in the short term, but they had an increased risk of intracranial hemorrhage and other major bleeding events. And in the long term, at 3 years of follow-up, there was no difference regarding mortality benefit or risk of developing CTEPH for these patients between the two groups. So it's still an active area of study. Where the ACCP lands on this right now, and again, this is a few years old, but they recommend considering systemic lytics for patients with a submassive PE who are starting to show evidence of clinical decline and have a low risk of bleeding. And so I think, to take it back to this case that we were just discussing, if that patient had had kind of more, if he decompensated in a matter of moments, but if he had been someone who had, you know, over a period of an hour started to get more hypotensive, was having a pressor need, I think that would be a case where we would be reevaluating what's his urgency for the OR. It seems like he's decompensating from a hemodynamic standpoint. And at that point, I think the conversation for lytics would have been raised. I think something else I heard people mention in the chat was this question of catheter-based treatment. These therapies, there's a few different ways that they're done. Catheter-based treatment can be used to deliver thrombolytic directly to the clot. It can also be used to just kind of go in and mechanically bust up the clot, particularly if the patient is not a candidate for anticoag or lytics. And there are also some ways to actually go in and kind of suck out the clot. What I also thought was interesting that I didn't really know that much about was that there are studies looking at whether or not using ultrasound waves can also kind of go in and further break up the clots. And it's also thought that maybe kind of breaking up the clot more basically creates more surface area for TPA to latch on and help bust up the clot if you're using lytic as well. But there's not really clear evidence that plus or minus use of ultrasound in that way is superior. The things that were evident to me in reading about this treatment modality is that the clot does need to be proximal enough to access. something that is worrisome is that if you're going in and just kind of mechanically disturbing it and trying to break it up into pieces, you could embolize some of that clot more distally, in which you've really kind of shot yourself in the foot. And so there are studies ongoing trying to assess which basically catheters and which devices can kind of break things up into smaller pieces, or kind of risk of that embolization with different specific therapies. Sorry, guys, I'm getting a page. I'm on backup risk. And then finally, the other thing that I think people like about catheter-based treatment is that the risk of bleeding is thought to be lower if you're using a catheter to direct your delivery of lytic. And so there's a lot of excitement about this because people think, hey, for patients who have high bleeding risk, but not an absolute contraindication, let's just do a catheter-based approach. But really, when you look at the actual availability of data, there's not a lot of data, and there's really no RCTs to assess if this is actually effective or not. There are some small cohorts where they think that after catheter-based therapy, there was an improvement in the RV to LV ratio, there was a decrease in mean PA pressure, but really there's no RCTs to help us understand the true effectiveness of this therapy. So there's a lot of excitement, but in reality, there's really not a ton of data to help us understand when it's effective yet. From what I understand, it seems like catheter-based therapies are at this point in time a little bit dependent on the institution and who is available to do them and how comfortable they are, because it's not yet a totally routine thing. It is also something that we think about for patients who have higher bleeding risk and maybe can't get a systemic lytic, but could get a lower dose delivered by our catheter, or they can't get any sort of anticoag in which you could do this mechanically with your catheter. And so that was the thing that the MICU attending was really thinking about, but ultimately did not happen. Surgical embolectomy for patients who have submassive PEs is really not very commonly used. It is reserved for patients who basically fail any other type of treatment, but I won't really discuss it more than that.
Question in the chat, Molly.
Mm-hmm.
Questions about half-dose TPA, or wondering if it needs to be given all or none, if there's lower intensity versions that have been looked at to weigh the bleeding and clot risk benefits.
Yeah, that is something that, from what I understand, is still being studied. Here, I'll scroll forward a little bit. So from what I understand about TPA, I've only given it once myself, and it was in a code. So I wanted to read a little bit more about how we actually do this. And so to talk about that, and as well as hopefully answer that question, it can be given peripherally. Central access isn't required. So if you're worried about that, you just need an IV. What we generally do as standard practice here in the US is use IV alteplase, and it's usually an infusion that's run over 2 hours of 100 milligrams. If you're feeling like things are more urgent, you can bolus it. You could also give a partial bolus and then run the rest. But these things where we're kind of giving it more quickly are not really effectively studied. So that's kind of just like a gestalt. Oh, I think things are bad. Let me just give it more quickly. But we don't actually know if that's better or not. But certainly in patients who arrest, it's given as a bolus rather than as if an infusion. There are studies now that are looking at trying to do 100 milligrams versus 50 milligrams for patients who have potentially elevated risk of bleeding. It sounds like there's not really a clear path forward with that yet. There's some concern that giving a lower risk of TPA up front means you're going to have to redose it because it's not really busting up that clot, and you should see improvement in the first hour. But it's unfortunately not really clearly understood yet. So I think it's a great question. There's not really a clear answer yet with what we know currently. Okay. We've got a few minutes left, and I wanted to hopefully spend it talking about this case. We have a 67-year-old man with an impressive PACURE history and COPD. He was acutely dyspneic and altered at home. He was intubated in the field, and he arrives efebrile, tachycardic to the 130s, breathing at 24, riding the vent, and hypotensive at 70/44. And notably, he cannot get a reliable SAT probe reading. He on exam is unresponsive, he is paralyzed, he is quite cold, his pulses are thready, and his breath sounds are diminished bilaterally. His EKG shows sinus tach, and on your bedside echo assessment, his RV is enlarged, as is his RA. You notice a positive DSIGN throughout his cardiac cycle, and his IVC is quite plump. So if this patient were your patient in the ED, and this was what you had done so far with your workup and bedside assessment, and also we kind of know what we're talking about with this academic half day, so a little bit of a spoiler alert, but what are you worried about and how would you stabilize him?
PE is in the chat.
Excellent. Specifically, what kind of PE?
Cardiogenic shock, massive PE
Yeah, agreed.
/ obstructive shock.
Perfect. So I wanted to comment a little bit about what are the initial steps that we can do to stabilize these folks while we're waiting for a more definitive intervention. Just thinking about basic ABCs, we've got the airway and breathing covered already, thanks to medics in the field who intubated this gentleman. He's seems to be doing okay on the vent, but it's our circulatory system, as Shri said, that we're really worried about with concern for possible massive PE and obstructive / cardiogenic shock. What I wanted to highlight was that fluids are things that we have to be really careful with fluid resuscitation in these patients. Generally they were in their normal state of health, doing their kind of normal things, and then this acute PE happens. So unless you know about, some history of illness before or reason for them to be hypovolemic, they're not generally going to be very hypovolemic. And so in a state where their RV is acutely failing, we need to be really judicious about using fluid, because giving them additional fluid may actually just worsen their RV function. And unfortunately, our assessment of what their volume status looks like with ultrasound is going to be hard to interpret, because in that state of RV failure, your IVC is already going to be quite distended and probably non-collapsible. And so there may be some other, clinical signs or ways that from labs that might hint at their volume status, but I would advocate being quite cautious with their fluids. Various guidelines suggest that norepi is a reasonable first line for vasopressor support. It has a little bit of positive inotropic effect. It only mildly increases preload to the right heart through venous vasoconstriction, so it's not going to overload and congest the right heart further. You could also think about adding vaso as the second agent, because that does decrease pulmonary vascular resistance, which could help. Inotropy is something that you should reach for early. We're all, I think, fairly familiar with dobutamine and milrinone. Milrinone has the added benefit of reducing pulmonary vascular resistance, which is really attractive in this situation. A lot of our patients do have, unfortunately, comorbid conditions, so we do have to be careful about using that in patients with renal failure. And finally, something that you can think about that will take a little while to set up, but is very helpful, is a pulmonary vasodilator. So inhaled epoprostenol will help dilate those pulmonary vessels to help offload the RV a little bit. Of note, the patient needs to either be, they need to have some positive pressure airway system in order for you to actually be able to deliver the inhaled EPO. So if they're just on nasal cannula, it's not going to work. They need either high flow or PAP, or they need to be intubated in order to actually have enough force to blow the inhaled EPO in. And so these are some ways to actually stabilize your patient while you're calling your PERT team and trying to figure out what to do. Thrombolytics are essentially our go-to unless there are strong contraindications. There are many RCTs in this population for massive PE that do show a short-term mortality benefit for patients with massive PE. when they compare systemic TPA versus anticoagulation alone. Long-term benefit for mortality is a little bit unclear. And again, as we were discussing earlier, I think the question of systemic lytics versus catheter-directed therapies, there's a lot of excitement for the catheter-directed therapies, but we really don't have our CT data yet to help clarify when they're appropriate for use. And I think some of these other data points we've kind of covered in discussion already. And so I'm going to move forward just because I know that we are running a little bit short on time. I think we're all familiar with who can, who cannot get TPA from working on the neuroservice. And so I've included absolute and relative contraindications here, but I'm not going to read through them right now. And thanks to some smart questions earlier in the chat, I think we've talked a little bit about what we do and don't know about TPA. So the last thing I wanted to leave you guys with was just shouting out the PERT teams, which exist at Harborview and UW. They do not exist at the VA, but I think if you ever have any concerns, talking to your MICU attending is a good first step. UW, this includes the MICU attending, the primary attending for the patient, the ECMO consult attending, a stat nurse, and a pharmacist. And at Harborview, it's similar. It has a MICU attending, ECMO, stat nurse, and the cardiology consult attending. Per ACCP's like dream of what a PERT team would look like. There are sometimes also other members such as vascular surgery, hematology, interventional cardiology, IR, but it's a newer intervention to basically try and assemble any team member who could have helpful information in trying to figure out a course of care for the patient. And so it's a little bit variable site to site, and not all sites have these. And we're still studying to see if they're actually effective in improving outcomes. They're also looking at other things like, does it increase the amount of procedures for patients? And if so, is that a good thing? But preliminarily, the sense in the pulmonary and crit care community is that these are really helpful tools to use. And so if you have a submassive or massive PE, you can call your operator to activate these teams at either site. And at the VA, again, I would just be reaching out to the NICU. I'm gonna leave this slide here and let you guys kind of review it on your own time, because I recognize that we're just about out of time. But I wanted to highlight that we should not necessarily reflex jump for a heparin drip for patients who have low risk PE that need anticoag. There's actually some data that low molecular weight heparin is better. But I think we sometimes just do heparin drips because that's what they were started on in the ED. But the slide, your takeaway should just be thoughtful about your anticoag choice and don't auto choose a heparin drip just because that's what I think we're used to seeing. And SUBSEG PEs, who knows, man. So I'm gonna stop there. And if anyone has any other questions, I'm happy to share what I know.
Question from Cody Gehring in the chat. With the goal of reducing pulmonary vascular resistance, wouldn't you prefer milrinone first line for obstructive shock as opposed to norepinephrine?
Yeah, I think often these patients are so hypotensive that you have to reach for a pressor because ultimately both milrinone and dobutamine are gonna, like one of their most common side effects is making people more hypotensive. And so I think you kind of have to at least have a pressor there ready to go if, as you're giving milrinone or dobutamine, you're noticing that blood pressure falling. And I guess the other thing is just logistically, norepi is something that is faster for us to actually get. And so certainly you want to be reaching for inotropic agents, but the timing to actually get those to bedside often means you're reaching for other things that are a little bit faster to get your hands on first.